We know back pain is one of the most devastating, disabling conditions affecting the entire world. These people were not faking it. They were told a lot of times that, oh, it's just chronic pain, it's in your head, you have to get therapy. And they get therapy and it doesn't work. And then they get 20 different injections and it doesn't work. I kind of set out to say, okay, which part of this is anatomical, structural, and which part is psychological?
Dr. Amir Vokshoor, board-certified spine surgeon and disc health expert, former chief of spine surgery at Providence St. John's. In this episode of the Commune podcast, we discuss why spinal discs fail, how modern life may be accelerating spinal degeneration, and why chronic back pain is so often misunderstood.
During sleep, our discs actually rehydrate themselves. We literally gain height through hydration of the discs.
Really?
Because of what we call tech neck, and we're seeing younger patients that need disc replacement. Doritos and happy hours after sitting all day doesn't end up well. It's extremely caustic to the spine. There shouldn't be a situation where the quality of our life just goes way down.
Dr. Vokshoor, what a treat. Thanks for coming over.
It's an honor. It's a pleasure.
So as I mentioned to you before we started recording, I've just endured and recovering from an excruciating bout of back pain. So I have a visceral empathy and understanding for not just only the physical dysregulation that happens, but also the psychological dysregulation that happens during those kind of bouts of back pain. So, and I know that I'm not alone, right? This is a massive issue, epidemic levels in our society for various reasons. So I was hoping that we could use our session together to provide other people that are going through severe back pain or chronic back pain with a bit of a game plan in terms of how to navigate that, from preventive measures to the ladder of treatment, from kind of the most unintrusive, uninvasive to the most technologically cutting edge, which I know you're on the bleeding edge of. And then, how do we recover and get back into motion, particularly for some of us who are athletes. So that's maybe the framing of our discussion.
Sure. Yeah, that's very rich. You brought so many incredible concepts that are truly near and dear to my heart because I deal with them every day. I love the fact that the first thing you brought up was empathy itself, which is, one of those like charged words. And I do believe like the healthcare practitioners have varying degrees of empathy due to a lot of different things that are going on, including burnout. That happens a lot. So a lot of my patients come for second opinions, et cetera, and they say, well, we saw these other practitioners and they're very good, capable surgeons with amazing resumes, but they didn't seem to care that much, or they didn't give me the time, or they didn't have the time. Frankly, there were too many patients in the waiting area. And that's become a lot more commonplace. So I feel like just delivering a sense that you care is a very important healthcare event that has to happen that sometimes doesn't. I'm astonished by how discogenic pain in general affects our psychology. Yeah. I've been astonished from day one. And, in neurosurgery, disc problems in general, especially early during training, are just not given the same weight as the effects that they have on society. We know back pain is one of the most devastating, disabling conditions affecting the entire world, from productivity to chronic pain to addiction. It affects a lot of different aspects of the human experience and predicaments that we are challenged by. Mm-hmm. But it's not given the same weight in our training because brain cancer and brain aneurysms and hemorrhages and other things that we deal with as neurosurgeons are, because they're emergencies a lot of times, they're given a higher weight, especially in training. I noticed that. So I loved spine from day one of neurosurgery. So I was always given the opportunity to go straight and see spine firsthand, because everyone else was looking for brain aneurysms and brain tumors to fix, all my co-trainees. So if you're watching, this is for you. But I always was astonished by the psychological effects of discogenic back pain. And I wanted to get to the bottom of it. I knew that these people were not faking it. It wasn't in their head.
Yeah.
And they were told a lot of times that, oh, it's just, you have chronic pain, it's in your head, you have to get therapy. And they get therapy and it doesn't work. And then they get, some of our patients get like 20 different injections and it doesn't work. So I kind of set out to say, okay, which part of this is anatomical, structural, which part is physiological, like hormonal or blood pressure or blood sugar related or nutritional related or microbiome related, and which part is psychological, which ultimately everything psychological is physiological. It's just we haven't quite been able to figure out the exact neurotransmitter configuration of every psychological state of our nervous system.
I'm curious as to many of the reasons why people land in your office. As you say, it could be structural, it could be psychological. I guess one way of you discerning the provenance of their issues is through a more extensive intake process. So I'm wondering, what does that intake process look like for you? And how does that differ from, the normal intake process that many of us experience?
It shouldn't be magic. Like the first thing they teach you in medical school is to take a history. Like take a history. And I always thought that was a little cheesy as a medical student. Like, of course you take a history. But as I've gotten to become a more mature doctor, I'm like, oh yeah, really take a history. So, which means some of it is details of timelines and things of that sort. Some of it is old trauma. Some of it is patterns of pain. And some of it is perception related. How does this person's wiring differ in a way that they're perceiving these insults in their nervous system as pain? And the nervous system has many ways of interpreting stimuli. Mm-hmm. And that's what's really interesting about it, because some people are like, oh yeah, I've had that pain forever and it doesn't bother me. And some people are like, yeah, that's the pain that's been with me since high school and I'm devastated by it. So you have to think about the perceptron, what happens in that person's brain that makes them unique, and then tailor an approach that fits them. So the intake process is, a lot of it is just, okay, what's bothering you now? What are the patterns that are bothering you, like driving, sitting, standing and walking? A lot of times, early morning hours are tough. Mid-morning hours are great. And then as the body continues with a challenging disc problem or a joint problem, later in the day, there's a fatigability to it. Mm-hmm. So some of that is structural, some of it is neural, and we have to discern the two by being a good clinician. And that's some of the basic stuff. And then other stuff is obviously old trauma, car accidents, connective tissue conditions like connective tissue disorders, like, Ehlers-Danlos syndrome, or things that are similar. And then what I like to call is, what are the weaknesses of the structure? Mm-hmm. Are you more of a ligament weak person, or a bone weak person, or a nerve weak person, or musculotendinous? I had a New York stay recently where a patient wanted to come see me and they couldn't come to California. And I said, I'll just meet you. I'll just have a quick meeting with you. And their MRI was, they were about to undergo surgery for disc repair, et cetera. And all their MRI showed that was really profound was psoas atrophy of the psoas muscle that no one had mentioned to this person.
Wow.
And I examined her and I said, you can fix the structure, but most of your problem is weakness of the muscles. And in her particular case, I don't think disc surgery would have given her the biggest bang for her buck. And it would have resulted in suboptimal outcomes, which we have sometimes in spine surgery and need to be considered, and further workup. And it turned out she had a neurologic disorder that was making her muscles weak. And she needed to go through an entire workup of neurology and get physiotherapy. And there was a intestinal gut component to it. So I do feel like spine is complicated enough that it deserves this multidisciplinary extra attention to all the systems that are related to bodies feeling well.
I think many of us can understand why back pain might be the result of a traumatic accident, right? Something happens and there's some sort of structural abnormality that results. But more often than not, especially when I hurt my back, the DMs and emails that I got were like, yeah, I was just walking down the street and I took a step, or I was picking up a pencil from the ground, something incredibly minor that then somehow trips this switch. I'm curious, like from a diagnostic perspective, like how do you unpack that? Because I'm sure that's what you hear a lot. I mean, I'm sure some people come to your office and be like, oh, I got into this awful accident.
Right.
But probably more often than not, it, is a result of something incredibly banal and prosaic. So how do you untangle that?
I totally agree. So I always try to figure out what was happening before that very minor accident. And once in a while we find it. Like, oh yeah, we went grocery shopping the weekend before after a night of drinking, and I was dehydrated, and we were at Costco, and we were picking up groceries and twisting our spine at the same time, and that motion may have led to some initial injury. That, I felt something, but it wasn't that bad. And then sometimes people really feel a pop.
Yeah.
But ultimately, it's the basket weaving of our discs called the annulus fibrosus, which is basically a proteoglycan structure, lattice structure, and it's truly acts like a basket for the jelly material. And there are dehydrating factors. It desiccates, it dehydrates, and sometimes there's radial and vertical tears in it that allow the jelly material, which is under pressure a lot of times, to be able to spew through and cause a disc bulge or a disc herniation.
Yeah, so maybe we'll go through some of the most common conditions that you see, from herniations to sciatica to stenosis. Like, what do you see most often? And then we can maybe walk through the ladder of treatment. Because, for example, you mentioned hydration. As I started to treat myself, hydration popped out at me as something that I had never even considered. And sleep also fell in that category as well. So anyways, we'll start at the beginning. What are you seeing from a condition perspective? And then what's that first ladder of treatment that you would recommend?
Yeah, I would say, I mean, you hit it spot on. Hydration and sleep are so important. But what I see in my practice is either like an acute disc herniation, where it's extruded, the fragment of the jelly material is actually hitting a nerve, and that causes severe back and leg pain, most of the time severe sciatic type pain. And the second thing I see a lot of is somebody's had sciatica years ago, they've dealt with it, and now their discs are collapsed and desiccated, and they just have lower back pain near their tailbone. And it's driving is achy, getting in and out of a car is a little achy, any flexion forward is achy. And that's pretty classic for what we call degenerative disc disease that can happen even after a disc extrusion has healed, but the jelly material has been absorbed. Yeah. So you've lost height. You've actually lost height in your spine. Those are the two most common conditions. And then initially, the lifestyle changes of, during sleep, our discs actually rehydrate themselves if your body is hydrated. The disc material is fascinating. It's not like your heart or your muscle that's constantly getting microcirculatory blood flow. It's one of those like mysterious parts of our body where by definition, it doesn't really have a lot of live cells in it. All the live cells are in the margins of it, and all the nerve endings don't enter it, but they're just on the margins, on the annulus, not in the dead jelly material. The jelly material is an embryologic structure that literally goes away, called the notochord. And so it, by definition, after age 2, you don't have a lot of living cells inside your disc. So it's all this very interesting cartilaginous jelly material encased in a basket, and it has some circulation of its own where it gets water from our vascular system, extracts it. And during sleep, we gain height. We literally gain height through hydration of the discs.
Really?
So if you're on a 23-hour flight and you sat the whole time or tried to sleep sitting up, hopefully you get an upgrade and get to lay down, but that doesn't happen always. So I feel like your discs are going to feel it. So during travel, many of my patients are more prone to injuries and dehydration during those travels.
That's interesting. So
with that thought.
Yeah, have a glass of water. Yeah, so just to anchor this in a little bit of my personal experience. So I had been traveling for about 2.5 months on book tour, and then I went to go take care of my dad, who is ailing in southern Florida. And on the very, very last day of this very long trip, I was just walking down the street, felt a little like twang in my back, and then of course immediately got on a 6-hour flight back to LA. And by the end of that flight, I couldn't get off the plane. I actually had to bring a wheelchair down the jetway. And as I tried to kind of dissect, my issues, like, of course, I didn't feel the pain in my back. Where I felt it was in this sort of crease of the hip joint in the psoas, and then some numbness in the left knee, and then quite a bit of sort of deep internal pain in the left hip. Now, I have a prosthetic hip from a total hip replacement, so of course my first concern was like, oh my God, I've dislocated the hip or something's happened there. But as I, began to kind of understand more about spinal anatomy, of course, like I had a herniated disc between L3 and L4 that was essentially like impinging that nerve as it was coming out. You'll have to help me as
Pretty
I go
classic.
through this. Like as it was coming out the foramen there or whatever.
Right.
And
We actually have two nerve roots affected. One of them is the upper groin, which is called the L3 nerve root. And then the other one goes a little bit toward the knee. That's the L4 nerve root.
And you know who gave me the best diagnosis? ChatGPT. because and we don't need to dwell on this unless you have other thoughts about AI and its relationship to spinal health. But one of the interesting things about my relationship there is that I could prompt it endlessly. So in some ways, it was able to do that thorough intake that a pain specialist in the Valley wouldn't do. The pain specialist was just like, okay, we'll give you a steroid injection. Let's go.
I think it's very useful.
Yeah.
I mean, I use a lot of AI tools myself. I think, good data in, good data out for AI.
Of course, I was prescribed oral steroids. And that's like a total normal prescription there, and to take the inflammation down. Are there other ways that one can relieve inflammation through diet or other protocols?
Yes.
In this kind of early ladder of treatment?
I mean, my wife had a very similar problem, similar episode to yours, and she was on a short course of steroids, which worked, but she continued to have pain and she didn't want to be on steroids anymore. So she came up with this whole kind of nutritional way of decreasing her inflammation.
Yeah.
And everything from like turmeric teas to teas I'd never heard of, to intestinal probiotic things. So she has become a mini expert in it because she beat her sciatica after a couple of bouts of steroids with these like more holistic nutritional methods. But I think mechanically, some kind of a manual evaluation of your back and seeing if you're a good candidate for inversion or flotation, like I feel like floating in the water can kind of make your spine weightless, which is really helpful. It's been in my case and for my patients. And then inversion as well as traction. So there are chiropractic methods that give traction to certain discs, and there are actual devices that do that. Now, I always say check with a specialist first before you have those things, because in the lower back, it's not as big of a deal, but in the neck, because the spinal cord is involved, sometimes certain maneuvers like traction or manipulation can lead to trauma of the spinal cord, which is sometimes devastating. So it's very important to have ChatGPT first, and then a specialist at your side that cares, that takes enough of a history to be able to guide you to the next steps. Because you're right. I mean, if the injection doesn't work and the steroid packs don't work and the holistic methods don't work, then what do you do? And that's a lot of times when patients come to me. But I almost wish like I was involved even earlier and guide them through, because I'm not a cut happy surgeon. I just want to see the course, because the heuristics of this computer knows the forks in the road because we've done it for 20 some years.
Yeah.
So the forks in the road are the curveballs that your back and spine throw at you as you undergo this process of healing. And healing is not a linear process.
Is there a role for peptides, PRP, stem cells? What's your take on some of those
Yes,
therapies?
and yes.
Yeah.
I would say I'm an early adopter of that method, and I've been my own research subject in those things because I suffer from joint inflammation, etc. So I think certain peptides have really proven themselves now to us, which is like things like BPC 157 and the usual ones, so to speak. And then there's some really exciting ones that are in research phase that are coming out for even for human cognition and increasing blood flow to the nervous system. I've seen some really interesting new discoveries that, you know, I hope to post on in the future when they become a little bit more scientifically proven, because I do feel like high integrity science will define our next phase of discovery. There's a lot of great influencer data, and then there is scientifically proven data.
Right.
And there's real world data, which we're trying to gather in our research institute all the time, which is, you know, what is the strength of evidence? What is the true percentage of success for each of these things? Like exosomes is a great example.
Right.
There's a huge debate about the efficacy of exosomes, which we know are beneficial in certain settings, especially for acute joint inflammation and healing, versus stem cells, which are entire cells that are potentially pluripotential in their ability to heal.
I was interested in all the different ways that I have agency, and that by extension, you know, individuals can take some degree of agency over their own pain.
Which I love.
So of course, you know, this came to diet and hydration and optimizing sleep architecture, et cetera, peptides, and then meditation and breathwork. What could I do there to actually improve my condition? And I remember reading James Nestor's book, Breath. There is a section in there, and I won't get it totally right because I haven't read it in some time. There is a place in Germany with people that had severe scoliosis, and they started to engage in supervised holotropic breath work.
Yes.
And they saw an amazing recovery in some of the patients there. And so I'm like, okay, I remember reading something like that. It's
Yes.
like, okay, how can I use breath as a way to, you know, control my nervous system or influence my nervous system in order to get on top of the pain, so then I can actually take more reasonable and rational steps to address my issue. So what are your thoughts here around meditation, breathwork?
I love that you brought that up. I feel like one thing that you are gifted with that I want to continue to emphasize to my patients and everyone is mindset. Something initially made you intend to get well. You said, I'm going to set on this path. So prior to you saying, I'm going to do meditation, breath work, whatever, I mean, how did you make that initial mindset switch? And this is the intentional part of our nervous system that I always try to empower my patients with, that, you know, it's not as light as like, oh, just think positively or just start meditating because you're going to get it. And, you know, sometimes that seems silly to someone in severe pain. So I want to ask you how you made that initial switch to get on the right path.
Yeah. Well, I'll
go back on.
Yeah, I'll have to be totally candid with you. In the initial phases, it was so excruciating and debilitating that I needed some painkiller support to get on the other side of the acute issue, because it was so overwhelming and I couldn't sleep at all. And I've never been anyone that has ever popped pain meds. But in this particular case, I felt like I just need to get on the other side of this acute situation in order to make better decisions and to take that agency. So I did. So the first, 4 or 5 days, I had a little bit of oxy, and I get it. I understand now why that has become an addiction issue, because it provides so much relief. That,
incredible. I'm so appreciative you brought that up, because I find some of my colleagues that say never ever prescribe narcotics, or some of my patients say I want anything but surgery. And sometimes, that's a reasonable approach, but I feel like I'm the kind of practitioner that wants to use all the tools in my toolbox appropriately and to get someone through a health event. And you're the perfect example. The charged opiate, epidemic was created because we were lacking balance in the system. So a system without balance will fail one way or another. But you obviously had enough foresight to get the pain down with oxy and then realize that that's not a long-term solution.
Yeah.
And that's also a really important switch. And sometimes it comes from fear. Oh, we had addiction in the family, or, I'm sober 20 years, I need to get off this oxy. And some of that is fear-based, some of it is obviously very wise. But how did you make the switch?
Yeah, I ran out. No, just, yeah.
That's awesome.
I was like, shaking the bottle. There's nothing left in there. No, by day 3 or 4, and I wasn't taking that much. It was just kind of, it was really most as a sleep aid, because I could only sleep in the fetal position. And this is probably not anomalous, because that position took pressure off of the nerve.
Some of the easiest,
and
it wrecks your shoulders, but it's great.
Yeah, well, this is a whole actually line of questioning I have about sleep and positional sleep for you. And similarly, the only way that I could walk was stooped forward. What do they call that? Kind of like the walking, that posture, because of course that helped to take pressure off the nerve. I couldn't get erect in stature, and I
probably couldn't easily sit down either.
Yeah, sitting was actually a little easier, but I couldn't get flat in any way.
But that's another really fascinating thing, because I've seen the classic disc problem cause a sitting pain.
Yeah.
And then there are patients that come that have more standing pain that can actually flex forward. And though in those cases, there's a loss of height in the motion segment.
Yeah.
And you suffer from what we call dynamic stenosis, which is a slightly different issue. But I wanted to go back to what you said about breath work, because, I feel like it's really underutilized. And my patients are so bored of me telling them to start deep breathing first thing in the morning, late at night, midday. They're so sick of me emphasizing it. But the lungs are like our immediate filtration mechanism. If we use the surface area of our lungs, we're already filtering a lot of toxins out and hyperoxygenating the nerves. And also CO2 itself, the carbon dioxide itself, I don't know if you saw in the breath book, they also talk about holding the breath. They all talked about CO2 retention as a mechanism. So much great literature and scientific literature on breath hold and divers and what happens to our diving reflex and how we can use that to improve our kind of autonomic nervous system and equanimity of the mind in those settings where the body is saying, please take a breath.
Yeah.
It's really interesting. And surfers and divers and long distance swimmers all work on this, which I'm really fascinated by. And that's why I love water in general, because it provides an atmosphere where we can really mess with our breathing cadence. But I would say deep breath work, in certain cases, holotropic breath work. I like what Wim Hof has done as far as like promoting it as a mental exercise. And I promote it, to everyone. And what I promote is more of a parasympathetic breath work, where you're trying to provide healing and recovery and change the sympathovagal tone, which is the relationship between your fight and flight mechanism due to pain and the vagus nerve, which is trying to bring recovery, rest, and digest mode to your body.
Yeah. Are there certain particular breath protocols, box breathing, 4-7-8, anything that you would particularly recommend?
Yeah, I always start with box breathing and 4-7-8 because those are the easiest ones to adopt.
Yeah.
And then my extreme is take the longest inhale you can, hold it, so it's more like 10, 10, 20, 10. like,
Wow.
like
Yeah.
it's really long and protracted, and everyone's lung capacity is going to be different. So I feel like messing with the longest inhale, holding it for the longest, exhaling it, and then having no breath and holding that for the longest, or as long as 20 seconds, for example, is my favorite exercise. And it really challenges the flexibility of your O2 CO2 exchange. I think I like starting with the box breathing. That is a Marines or the SEAL team that started it. I love that. I have my daughter do that at night when she's unable to go to sleep. But box breathing followed by a 4-7-8 is the way to start this process. Don't get into the longest levels until you're ready to challenge your body. And sometimes what I do is I do more of a preparatory 4-7-8 and then do the longer holds at the very end of the practice when you're ready to be done with your meditative breath work in the morning. And that's usually the way I like to do it.
More on the kind of more pure meditation side, certainly there's a aspect of meditation where you're just witnessing phenomena arise and subside in consciousness moment to moment, right? And that phenomenon might be the sensation of pain. By getting yourself into that mindset, you can more inhabit this understanding that this pain is ephemeral. It is, it will arise and it will subside. And that can provide just a certain amount of relief in and of itself. Is that how you are thinking about meditation and mindset, or are there sort of other dimensions to how you think about the utility of meditation?
I love that you brought it up, and I think your messaging around it is very kind of precise, which I love also. I've been meditating for over 10 years now, and I used it initially as a way of dealing with injury. But as you know yourself from personal experience, it gets difficult when you're in severe pain to calm the mind down to a level that you're just like, oh, that's just another experience that I'm feeling in my plug and play of stimuli. Right. And the body just doesn't allow you sometimes with the amount of physical pain that you're experiencing to do that. But I still think engaging in a mindful exercise helps pacify or at least slightly diminish the pain that we're experiencing. There's brain networks that are activated as a result of acute versus chronic pain. And by engaging in that mindful exercise, I feel like we dissect through, or at least cut the bond between acute and chronic pain. Because everyone's going to have acute pain in their lives. Right. But if we can avoid the chronic pain that the brain has produced, as opposed to the ongoing stimuli, I think it's really important, and especially important in spine. So I think that's where mindfulness really comes in. But I have to say, if your sciatic nerve is hurting severely while you're meditating, you need to change positions. You need to get somewhat comfortable. You don't have to sit there and take it.
And that brings up another question I had, just to go back on sleep. Is there an optimal position for sleeping that can prevent or minimize back pain? For example, would you advise against sleeping on your stomach? Or, I'm curious because, and again, this is a little bit personal question for me.
Yeah, I think there is a lot of evidence on all sides. To me, getting sleep, restful sleep, is the most important.
However you can get it.
I always tell my patients, get restful sleep. Yeah. And I have myself, I've had shoulder surgery. I have messed with every possible pillow you can possibly imagine. I have practically a physical therapist office in my bedroom to, as far as like the amount of gadgets that I've tried. And I try to tell my patients, depending on whether they're suffering from certain joint abnormalities, if your spine is not hurting, sleeping on your back with a lot of pillow support is the best, if you're able to do it. If you have certain, back disc problems, which happens a lot to my patients, a more lateral fetal position with the knees curled up with a pillow between the legs is the most comfortable. Yeah. And it's optimal because the spine is with a good firm enough bed that your spine is not doing the parentheses.
Right.
So you want to have a firm enough bed that your spine structure is supported. And there are pillows for shoulder, there are pillows for the neck. So the neck has to be in a somewhat neutral position. But if you're tossing and turning, the height of the pillow needs to change based on where you are. So I always say get a big and soft enough pillow that you can modify mid-sleep if you're not getting good sleep. To make it more bunched up if you're to your side, to make it less bunched up if you're on your back. And I think getting restful sleep, including deep sleep and REM, is the most important.
Yeah. Yeah. So one more little line of question before we talk about some of the more modern surgical techniques, because I was experimenting with everything, right? So red light therapy, TENS. I have this crazy pen electromagnetic frequency machine up in my house here. I'm curious, for any of those therapies, if you've seen, decent results.
So certainly red light has a place, especially for decreasing inflammation and making tissues, kind of engaging the injury. I've seen some results with PEMF. Most of the PEMF devices I've used are great for acute pain and kind of a maintenance. They make the tissue feel better. Yeah. They don't reverse any major anatomical abnormality. So unless they're truly medical grade and you're going to a biofrequency lab or spa, you're not going to get the same efficacy as the little homemade products. Not that there's zero benefit to them. They're just not going to be game changers for you. They're great maintenance things, but they're not going to be game changers for you.
You mentioned this briefly, that herniated discs or herniations can actually heal themselves, that the immune system or macrophages can go and eat it or whatever they do, absorb it. And so it's not a terminal sentence to have a herniated
disc.
Yeah.
And the weird thing is the bigger the disc herniation is, the more likely it is to be chopped up by the macrophages, especially if it separates itself from the mother disc.
Okay.
So from the original position of the jelly, if it extrudes into a nerve, but then gets separated because there's no longer flow or support of the jelly material to that disc. Right. You can call it blood flow, but it's most likely that weird circulation that discs have. Then it gets chopped up a lot quicker.
But a fairly commonplace surgery now, as we wade into the optionality of surgery, is to essentially like go in. And I know that this process has changed considerably, because it used to be kind of just an incision. You go in now. I think it's happening with like dilation.
Tubular dilation is one of them, and endoscopic cameras is another way, where we go from the side of the spine and barely enter the spine at all.
I see. So you come in from the side.
Yeah. The incision is like almost on your flank, and the camera is placed into what we call the foramen, where the nerve is exiting. Right. And then right underneath the nerve, there is the disc herniation. It's better for certain types of disc herniations, and that's why you need to have like intimate knowledge of the anatomy. But it works. It works great, and it's outpatient. People go home the same day. Wow. And it's, people go home in 2 hours, and it's quite impressive that way.
And is this generally happening in the lumbar spine or?
Yeah. In the cervical spine, endoscopic methods also work. But in the cervical spine, our least invasive thing is truly replacing the bad discs. And it's so easy. It is from the front, and it kind of freaks people out, but it is from the front. And if you have an expert surgeon, it's done so meticulously and easily, and it's been an absolute game changer for my practice.
Okay. So explain that a little bit more. So, we have our cervical spine up here. What are there? 5?
There's seven cervical vertebrae.
Right, 7.
12 thoracic, 5 lumbar.
Right, yeah. And so you go, are the discs that you're replacing, are they like bio-individual to the patient? And how do you 3D print those? I mean, how do you even make them? How does that work?
It's great. We need to 3D print discs, Paul. This is for you. And this, I talked to a lot of engineers and
are they titanium? I don't even know what they are. What are they made of?
I feel like, dentistry is a little ahead of us. When you go to a dentist office, they print your size tooth and put it in there. Spine, goes through the FDA process. There's a lot of great discs out there, and now our choices are quite immense. 10 years ago it was only like small, medium, large. Now we have like things like large, deep, large, shallow, extra large, deep, extra large, shallow, to really get the perfect fit for the patient's disc, which is absolutely essential. And then there are kinematic considerations of constrain versus no constrain that also should match the patient's inherent stiffness. And there's a lot of shop talk. We have, WhatsApp messages with some expert surgeons that are constantly arguing about this very concept. But, I think if you have an expert arthroplasty surgeon, disc replacement is superior to any other spine surgery we've ever performed. Wow. So it's one of those like absolute game changers that, it's like you go to a room and you say, who would like back surgery? And you see how many people raise their hand. Yeah. And now with the disc replacement, I'd be the first one. If I had that problem, I can confidently say I would love a disc replacement if I have a disc problem in my back or my neck, especially the neck.
And especially, this is a little bit random, but I was thinking about this morning. I remember when I grew up, there was no cell phones. I mean, there were eventually, right? But I remember everyone was always like this, right?
Yes.
Do you see less injury to the cervical spine now because people don't actually have to talk on the phone like this?
No, we see more.
Oh, you see more?
This.
Oh, yeah. Okay.
Because of what we call tech neck and text neck, we actually see more. And the discs are wearing out faster. We're seeing younger patients that need disc replacement. And my colleagues, my partner always says, why are you giving people a cervical collar? And I'm like, because for a week or two, I don't want them to text like this. Yeah,
to look down.
I want them to get used to just what actually being straight is, which we never are. I mean, if you practice rolling your shoulders back and being straight with your neck at least once a day, I feel like it is a great postural reminder. So reminders of getting out of your seat, even if you're on your laptop for hours, every 20 to 30 minutes, rolling the spine straight, trying to stand erect and extend it. I think it's great, even during work hours. Some people have stand-up desks. Some people use balls to sit on. All those ergonomics are great to engage the spine. I think core strength is essential for lower back health, and upper neck and upper back and neck exercises that are posturally conscious are very important because discs are going to wear out anyway. You're just trying to make them wear out in a way that's symmetric, that doesn't lead you with severe kyphosis or hunchback.
Hunchback, yeah.
Because if it does, then you're going to need a disc replacement.
Yeah, one of the other things that I found myself doing as I was recovering was almost sort of reteaching myself how to walk, primarily barefoot, or kind of I wear these sort of barefoot mimicking shoes that kind of have a minimal sole. Like my wife, I always like to tease her. She's like my shoes. She has a minimal sole. Not really. I just like to tease her. But that, just intentionally walking and learning how to actually walk properly. So in a way, again, this was sort of a silver lining to hitting rock bottom, is that, you get to reapproach your life with more intentionality. So this was
I love that. Walking is my favorite rehabilitative exercise for all my patients. And even after surgery, they're like, what can I do? I need to get back to the gym. I'm like, the first few weeks, I just want you walking. You can increase your walking ability, but walk consciously, walk with intention, walk with actually taking inventory of your balance, of your proprioception, of where your legs are in space, how your knees are doing, how your hips are doing, how your ankles are doing. Are they mobile? Are they flexible? And I think it's absolutely essential. So I use even, I'd say, grass or beach walking to get the bare feet to actually get a lot of proprioceptive feedback. Some of our patients have spine problems and neuropathy. Neuropathy is like numbness in the bottom of your feet.
Right.
Sometimes it's diabetes related, sometimes it's idiopathic. So really important that we get that haptic feedback to the little nerves in the feet.
Yeah, it's funny that you say that. When I was recovering from my hip surgery, it was actually a relatively slow recovery. The inflection point in the recovery was I went and visited my dad in Southern Florida and spent 2 hours walking on the beach every day barefoot. And there was something in, I think, the the connection of my feet directly, all the nerve endings in the bottom of my feet, maybe connecting directly with the ground and the sand. Maybe that's a little bit woo-woo. But I think it was also the engagement of all the little helper muscles and the intentionality of the walking that happens on the beach. And that was the game changer, was that and getting in the pool every day. And
great.
Swimming, and that was a game changer for me. And
that's amazing.
On the other side, I was back on the tennis court, so that was good. You talk about disc replacement in the cervical spine. Is it more complicated in the lumbar spine?
Yes, because the lumbar spine is a bigger part of our body, and we usually use a vascular surgeon to make the incision and gain access to the disc. So.
You're going through the front still?
It has to be done through the front. So it's like a belly incision.
Right.
It's a belly incision, usually underneath the umbilicus, the belly button. So for females, I call it a C-section incision, which they don't mind because it's super low and it doesn't cosmetically interfere with everything. But upper lumbar levels are more near the belly button. Depends on what level. But now, I mean, we're gifted in Los Angeles with amazing what we call access surgeons, which are vascular surgeons that specialize in spine access. And they do it all over the city all day, and they are really good at it. I mean, it's extremely rare to have a complication, but it is more to do. So recovery is a little bit longer. But, a cervical disc replacement, you go home 2 to 4 hours, or you spend a night at the hospital. If you're done at a hospital, you're older, or there's more than 2 to 4 levels, or more than 2 to 3 levels being done. A lumbar, you usually go to an aftercare, or, again, spend a night at the hospital. Just a little more care to make sure the intestines are working well afterwards, urination is working well afterwards. The anesthesia has not affected those systems.
Yeah. And so you're going through the front for the actual disc replacement itself. Are you doing facet work as well and through the same incision, or how does that work?
So the facet joints are actually in the back of our spine.
Right.
So back of the neck and the back of the lower back. And there is finally, after eons, there is a bona fide facet joint replacement device that we have.
Wow.
And it's called the TOPS device by Premia. You guys can look it up online. It's the first facet joint device that works. And it's as a screw system, so it looks like a spinal fixation, just like the rods and screws used to, but it's actually more of a suspension shock absorption device. It's really fascinating engineering.
Amazing.
And we happen to be the only practice to combine those two. My junior partner, Dr. Jared Ament, has combined disc replacement and facet replacement, and we've written on it extensively. A 360 spinal replacement without a fusion, because the alternative has always been to put rods and screws in the back or to put spacers in the front to immobilize the motion segment.
In that kind of old school methodology, I assume that's then much harder to get back to like where you were in terms of mobility and.
Well, it has implications. It may give you immediate stability.
Yeah.
The immediate stiffness is not as concerning. What happens months to years down the road as a result of that loss of motion is quite the problem in spine surgery.
Yeah.
And not only think about a motion segment of any joint. There are certain muscles and tendons that move with that joint because of that motion. If you think about a spinal motion segment that doesn't have motion, then that segment's assigned musculature, nerves, tendons, they're almost like quiet.
Yeah.
They tell the brain, we can't move anymore.
Yeah.
We're done. So the next guy above has to work extra hard to get you the same upright posture, gaze, check your blind spot, watch a tennis match. All those subtle things that used to happen as a shared load happens as, additional load on the segments that are still moving. And if those are wearing out, then that wear out becomes faster. We call that adjacent level degeneration.
And does that play into some of the zeitgeist around people's skepticism around back surgery? I mean, there's a lot of surgeries that people seem more willing to subject themselves to than back surgery, right? Back surgery always gets a little bit of skepticism associated with it. You're obviously dedicated to changing the game on that. Is that legacy due to what's the skepticism legacy about?
Again, if you go into a room and say, who would like back surgery tomorrow? No one will raise their hand because of the terrible reputation that it's gotten, mostly because the innovation front, we've been missing the Tesla of back surgery, maybe until now with this Premia device and this disc replacements. We're missing that disruptive thing that says, what is the spine supposed to move like? And can we restore that motion? Mm-hmm. Can we replicate the way the spine, when you go to a hip or a knee surgeon, their first thought is not to immobilize your hip or knee forever.
Right.
Like, think about it. They, and since the 70s, they've enjoyed this additional, it's a restoration of a joint as opposed to immobilizing it forever.
Yeah. Is it just because the back is so much more complicated, really?
Indeed.
Yeah.
Yeah. Even these devices that I mentioned have only been approved by FDA in the past year or two and are only approved at one level. Mm-hmm. And so in spine, there's 66 joints in the back and 7, 12, 5 of the vertebra with the adjoining discs. Yeah. You could have a problem anywhere there.
A lot of back pain and the prevalence of back pain due to evolutionary mismatches. And I guess what I mean by that is that, evolution is very slow. Like we were designed a particular way, but now culture is very, very fast, right? We had the agricultural revolution some 12,000 years ago. That put us in positions that maybe we were not designed to be in. And then, of course, you had the Industrial Revolution, and that put people in factories. And then you had sort of the technological revolution that put people at desk jobs, sitting generally all day. Is what we do misaligned with how we're designed?
100%. 100%. I mean, you have a much more eloquent physiological way of or philosophical way of describing it. What I'd like to say is Doritos and happy hour doesn't, after sitting all day, doesn't end up well.
Yeah.
So you have processed foods. You're sitting at work. You're sitting at home. You're sitting watching sports. It's extremely caustic to the spine, our current lifestyle, other than driving everywhere. I mean, it's the spine is supposed to move. It's supposed to have gentle therapeutic motion. It's supposed to, and also our nutrition goes into it. Our immune system goes into it. Mm-hmm. So how your microbiome is being fed on a daily basis affects your spine because it affects your mood, affects the stiffness of the motion segments, and how active you are. Mm-hmm. Mobility, life is motion. So keeping the spinal motion segments going through walking or gentle exercise, cardiovascular exercise at least twice a week. And then the nutrition debate is hot. It's a hot topic. And I know there's the whole
new guidelines,
red meat camp, the plant-based protein camp. And I don't seem to have a camp to fall into other than to say protein is absolutely essential, but so are fats. Ideally not saturated fats, but our nerves need fats. Yeah. So this whole anti-fat thing has also been a problem because people are sometimes obviously anorexic people that are having spine problems and having protein malnutrition are still scared to eat.
I think hopefully the conversation is changing from weight to body composition.
Yes.
Not really what the old school scale says, but muscle mass and body fat percentage, et cetera, because obviously you can gain weight and put on good lean muscle. And I assume that good musculature, certainly core musculature, has got to be good for maintaining back health.
100%. Yeah. And I also think food is part of our culture. Mm-hmm. So we have gatherings around it. We have nutritional celebrations around it. We have a birthday cake. I feel like challenging all of those is great. There are people that do certain tonics instead of alcohol now. There is certain adaptogens that are becoming regular in happy hour. So I like the fact that we're rethinking all of it.
Yeah, quitting alcohol was at the top of my list when I was really suffering with the back pain, which didn't make me the most jolly New Year's Eve partner or Christmas dinner partner. But I found personally for me that alcohol was making the pain worse. I mean, obviously it had like a analgesic effect for, a couple hours.
Right.
But then, it's fragmenting sleep. You're waking up dehydrated, all of those things that we talked about. So it sounds like
Agree.
alcohol is probably off the list if you're suffering from back pain.
As much as I love a nice glass of wine, I have to advise that to my patients. It definitely disrupts sleep. It messes with heart rate variability, which is an important part of stress recovery. It's a solvent. It's bad for nerves. It can lead to neuropathy. Minimize alcohol at all costs. And as I said, I love a nice glass of wine with dinner, but it's a problem.
So we talked a little bit about some of the prevention techniques. You mentioned a ball chair, that will engage core. Are there any other kind of preventive protocols and techniques that you would recommend?
I think you've mentioned most of them. Depending on where the injury is, there are some subtle things that an expert practitioner or a physical therapist or a doctor can guide you through. But you start your day by asking yourself, is this a recovery day or a training day? Mm-hmm. And mindset, movement, and breath are the first three things that I would say. So mindset is, am I intending, do I have a busy schedule? Yeah. Can I get some recovery out of this day? Or do I need to train today? Movement is early motion of your spine to just warm things up. Every joint loves a little gentle motion early on. Mm-hmm. Some of my patients with severe arthritis need heat or that shower to just get things going. That's really important. And then some breathing, like we talked about. Like you can start with just 10 deep breaths in the shower or something like that to just get the filtration mechanism of the body going, get it started on the right track. But most of the things you mentioned are, I think, essential, depending on whether the injury is acute or chronic, whether it's more of a muscular ache versus a true structural problem. There needs to be an individualized regimen for each person.
What are you most excited about in connection with the new frontier of neuroscience and of spinal science?
I'm most excited about the fact that this conversation is occurring at a level that the public can actually engage the medical professionals and ask questions from us. And, concept of brain health and spine health sounded a little woo 10 years ago, even in my spine surgical colleagues' practices. When I said it, they were all like, what are you talking about? That's all in their head or something like that. And I was always an advocate for patients that did not have typical physical findings. So the merging of psychology, physiology, and structure of spine and the nervous system, as that informs the practitioner and the patient about what the problem is. And then use of AI and other tools to get more real-world data to improve the entire process of healthcare and healthcare events around spine and brain health excite me immensely. And I'm a structuralist. I love detailed anatomy. And I love getting completely immersed in how can the structure be a little bit more optimized. And it can be something very subtle like a peptide or changing eating habits or doing something better for sleep to have better long-term habits. But also microsurgery, endoscopic approaches to shave a disc down a little bit, but not do a massive intervention, even though someone has severe scoliosis. Don't look at the obvious, look at the subtle things to say, can we get 50 to 70% improvement instead of a 95% improvement? And are we okay with that? So some of those harder conversations, I think, in spine are absolutely needed, and I'm excited about that.
So for someone like me who's kind of on the other side of the most acute issues, of course, all I want to do is get back and grind on the tennis court. But, I know that I have, some diseased, kind of L5, S1.
Yeah,
I know I have a little, that herniation, L3, L4, which seems to have, it's not impinging on the nerve as much anymore. So I'm not experiencing that pain. So of course, and then I'm back like training again and, building core. But there's a little voice inside my head is like, don't go back out there on the tennis court. You're just going to like fuck yourself again. And you're going to be back where you were. And so I'm kind of wrestling with that a little bit. Like, what do you say to someone like me, you know, who takes their athletics and seriously, like, you know, can I get back out there and feel confident?
Absolutely. So we deal with, you know, professional athletes that are truly made of a different physiology than you and I. But I love those guys.
I love those guys.
But I'm one of those like unfortunate weekend warriors that doesn't have time all week, but then has to get after it on the weekend. So I feel like doing this recovery versus training mentality, you know, for certain sports, it's sport related physical therapy. To get, you know, for example, for tennis, it's a lot of side oblique work, as well as leg flexibility, hip flexibility, knee flexibility, ankle flexibility, and core strength.
Yeah.
So I absolutely think you will be able to play full-on tennis. And if you cannot, we should review your MRI and at least give you an accurate diagnosis why you cannot. There shouldn't be a situation where the quality of our life just goes way down. Now, your tennis may have to change a little bit.
I know.
So that's hard for some people.
Yeah.
But I feel like modifying the original activity to some levels initially. So for golfers, it's chipping and putting instead of driving.
Right.
There's the edge of discomfort that I like to describe to my patients and my athletic patients to say, can we take you to the edge of discomfort before crossing it? And that's what I would say. And you're going to have oscillations. Some days you're going to play a tennis match, have zero pain.
Yeah.
And then the next month, you're going to play one and say, oh, I tweaked my back again. So it's a vulnerable part of your structure.
Right.
And I feel like you need to respect that vulnerability and know that it's either training or healing. But it's not insurmountable that you should be able to play tennis again at your 75 to 90% maximal capacity.
Okay, good deal. Well, you've had a really fascinating life, and maybe to bookend our conversation, you know, we started with a discussion of empathy, and you know, you clearly have that in spades as a doctor.
I appreciate it.
And just as a human, and that comes through just even in the conversation. And I think that's been an aspect that's been really underappreciated in our medical care world, which is, you know, dominated by, 7-minute visits and a lot of administration and haggling and, you know, insurance rebills, et cetera.
A lot of documentation.
That at the core of what you do is actually helping people and identifying their suffering as your own to some degree and indulging in their joy, the joy of their recovery. And I've got to imagine that that's why you got into it in the first place.
Absolutely. I mean, I didn't know it was going to be this gratifying. I thought, you know, you can fix people and you can empathize with their pain, but it's absolutely its own drug in medicine. And it's the only thing that keeps doctors going. It's the gratification. And it's not even, you know, you can call it altruistic or whatever, but it actually feeds your own self. Yeah. It's been proven that to be of service creates happiness.
That's right. What are all the ways that people can find you?
I'm on Instagram at Dr. Vokshoor, DrVokshoor. Thank you for following. I really enjoy your podcast and your take on the variety of subjects that you take on. So I really do look forward to reconnecting in the future. And for those who are listening, you can have a free MRI review or a consultation by me if you mention the Commune podcast by calling the office or emailing us. And the office is 800-899-0101. And my website is drvokshoor.com. So drvokshoor.com.
Okay, Amir, thanks so much, man.
Hey, it's been such a pleasure.
Yeah. Thank you for listening to today's episode. For more of my weekly musings, along with ad-free episodes and live stream conversations, head over to my Substack at jeffkrasno.substack.com. I also want to let you know about our course platform over on Commune, which contains over 3,000 lessons and practices from the world's leading integrative medicine doctors, health experts, and yoga, fitness, and mindfulness teachers. It's a living library for holistic well-being. And you can try it for free for 14 days at onecommune.com/try commune. As a reminder, the audio version of my new book, Good Stress, is available on Audible, and you can listen to it for free as part of your premium Spotify membership. And if you prefer the old school analog option, well, you can pick up a dusty old scroll at goodstress.com and get over $900 worth of bonus courses from some of my biggest influences, including Dr. Mark Hyman, Dr. Zach Bush, and Dr. Gabor Mate. As always, feel free to reach out to me with comments, questions, or criticism of the constructive variety at jeffk@onecommune.com. Okay, that's all from the Commune for today. My name is Jeff Krasno, and I am here for you.